Okay, here is a short review of cystic fibrosis. Some of the important pathophysiology to remember is this is a genetic disorder. We'll see thick, sticky mucus, and it'll affect many symptoms, not just respiratory. So it's a common genetic disorder that we see in Caucasians predominantly. It's an autosomal recessive trait, so if both parents carry it, each pregnancy has a 1 in 4 chance of resulting in a child with cystic fibrosis. Most affected are the lungs with increased thick mucus. It'll cause, retention, obstruction. They're at risk for pneumonia, hypoxia, hypercapnia, and acidosis. It also causes increased electrolytes in the sweat, increased viscosity of the pancreatic mucus-producing glands. That leads to blockages of those ducts. And so a lot of times they're not able to get those pancreatic enzymes into the duodenum. And so then we end up with impaired digestion. And so you will see these patients that often with each meal, they will get pancreatic enzymes, and there'll be multiple pills, and they're large, with these pancreatic enzymes. The book also goes in to talk about with this pancreatic dysfunction, how then they're at risk for developing diabetes. So some of our complications that we want to be aware of are they're at risk for chronic respiratory infections like pneumonia. We mentioned acidosis with hypoxia and hypercapnia. They can end up with a pneumothorax because of pulmonary fibrosis, pulmonary hypertension, chronic sinusitis, and then we already talked about that due to the pancreatic problems, they can end up with diabetes. They can also have reflux, so GERD are some of the common complications that we'll see. So what are some of the things that you will see in your assessment, or what do you want to do? So here are some of the non-pulmonary assessments that you'll see. So assess for GI symptoms such as large bulky stools that may have undigested food. You may see fatty stools or very foul smelling stools due to the protein in the stools. We mentioned GERD, and you'll see some malnourishment with them and vitamin deficiencies, possibly even some osteoporosis, so problems with the bones. With the pulmonary symptoms, you want to make sure and do a good assessment, auscultate the lungs. You might hear some wheezing. You might see a non-productive chronic cough, dyspnea. You might see any signs of upper or lower respiratory infections, or even some decreased breath sounds. Assess these patients for, barrel chest, clubbing, cyanosis, lack of weight gain, anemia. Ask about any respiratory infections with them. The lab test that you will see ordered with this, the sweat test is what will positively diagnose cystic fibrosis. And so you'll see that ordered when we're trying to screen and identify patients that have cystic fibrosis. So we'll do chest x-rays to look for any pulmonary changes. You'll see pulmonary function testing done so that we can really look at the extent of pulmonary dysfunction. And then you might even see stool samples done to really look at fat and enzymes that may be being excreted through the stools. That can help with diagnosis as well. Some of our interventions that we're going to do, you may see if we have any indications that they are prone or, have an early infection, we'll see early treatment and maybe even prophylactic antibiotic treatment. These are patients that we will do lots of work on making sure that they have good airway clearance. And so they'll often have chest physiotherapy ordered, percussion, we might be doing postural drainage. They can have vibration vest on. We'll do exercises that help with that mucus clearance for them. So they have really stringent chest physiotherapy or CPT treatments that they will do regularly. We'll see meds such as bronchodilators and medications to reduce inflammation. And again, we mentioned pancreatic enzymes are going to be given with meals. There are some surgical treatments, would be lung transplantation. It doesn't cure it because they still have that genetic dysfunction, but it can extend their life. And they're still at risk of infection because now they're on those anti-rejection drugs, and they can have high rejection rates with them. So with our